Hi, my name is Jeannie Lee, and I'm faculty at UCSD Medical Center in the Division of Trauma, Critical Care, and Burns. And I'm here today to talk to you about chest trauma. Chest trauma has been around for a very long time. Most of it was penetrating back in the early days, especially when there was wartime. We learned more about penetrating trauma when President Reagan was shot and he was brought to Washington Medical Center and was found to have a bullet lodged in his chest. Most notably with blunt trauma, we've noticed a rise with more motor vehicle accidents that have happened in the last few years. I'm going to talk to you about chest trauma, and this is the area that I'm going to talk to you about. Mostly injuries to the lungs, to the heart, and to the chest wall itself. These are the lungs, and you can see that the heart sits between the two lungs on each side. And this is a cross-sectional view. You can see again that the heart sits in the middle. It's surrounded by the lungs, and the ribs sort of perform this protective casing around all those structures. Trauma causes more than 100,000 deaths and more than 9 million disabling injuries annually. And chest injuries alone are responsible for 20 to 25% of all trauma deaths. Blunt thoracic trauma in particular is responsible for 20 to 25% of trauma deaths. And the most important cause of blunt thoracic trauma, as I mentioned before, is motor vehicle accidents. 25% of blunt trauma fatalities are a direct consequence of chest injury. And blunt thoracic injuries are responsible for 8% of all trauma admissions, and most of these, again, are due to motor vehicle crashes. Now I'm going to talk to you about specific injuries, and in particular the major injuries that you're going to find, especially when you're doing your primary survey in the evaluation of a trauma patient. First, I'm going to mention penetrating chest trauma. Most of these are associated with pneumothorax, and 30% of these will be associated with intra-abdominal injuries. But in general, these are the things that you're going to find in the primary survey on somebody who presents to you after blunt trauma. And these are the things that are known to be immediately life-threatening. Tension pneumothorax, open pneumothorax, also known as a sucking chest wound, flail chest, massive hemothorax, and cardiac tamponade. And we'll go through each of these. Tension pneumothorax is when the air collects in the pleural space under pressures exceeding atmospheric pressure. This pressure is transmitted to the mediastinum and can result in the shift of the heart and the great vessels away from the side of the pneumothorax. As you can see, this is a picture of a tension pneumothorax. And this is somebody who has a large pneumothorax in the right chest, and you can see how the heart and the structures are shifted way over to the left. The diaphragm is being pressed down, and you can see that the trachea actually is shifted over to the left side as well. This is someone who has a pneumothorax on the opposite side, so you can see that the whole left chest is actually filled with air. The heart is being shifted over to the right. The border of the right heart is a little bit farther over than you would expect, and you may not be able to see this, but the trachea is also deviated a little bit over to the right. Treatment of a tension pneumothorax is putting a large bore angiocath needle into the second intercostal space, right about where that arrow is pointing. And the technique for this is to find the second intercostal space, place the angiocath over the second rib, therefore not damaging the intercostal vessels and nerves, and sliding the angiocath into that space. What that does is that immediately relieves most of the pressure that's causing the tension part of the pneumothorax, and at least buying you some time until a definitive chest tube can be placed in order to definitively relieve the pneumothorax. We're going to move on to open pneumothorax, which in some circles is also called a sucking chest wound. The problem with this is that air is allowed to enter the pleural space from the outside of the body. The patient is then unable to ventilate because air preferentially goes in and out of the chest wound rather than in and out of the trachea. Treatment of this includes placing a three-sided dressing. And if it's difficult, you may place an occlusive dressing and then treat it as if it's a closed pneumothorax and use a needle thoracostomy to prevent tension pneumothorax. So this is a patient who has an open pneumothorax. You can see there's a big wound in the back, and this wound is going to allow air to preferentially enter the lung or enter the pleural space rather than the patient being able to expand the lung by breathing through the trachea. Treatment of this is going to be a three-sided wound. You put an occlusive dressing, so Vaseline gauze or anything that you have that's occlusive, placing a barrier on three sides so that basically it acts as a one-way valve so that air can get pushed out but not sucked back in. This is a little more popular done out in the field as it's a simple way of treating an open pneumothorax, because once the patient reaches the hospital, they should be able to undergo definitive treatment. Next thing we're going to talk about is flail chest. And the definition of a flail chest is fracture of more than 3 consecutive ribs in 2 or more places. And there are a couple of important features that are associated with flail chest that are going to make it a little more complicated than just managing rib pain. One is that it's going to be associated with pulmonary contusions very often, and there's unstable chest wall mechanics and pain that don't allow patients to ventilate properly. This is a diagram of a flail chest. You can see that there's 3 ribs that are fractured in 2 spots. So basically this segment acts in an isolated way in that when the patient breathes, it doesn't move with the rest of the chest wall. You can also see that flail chest is also associated often with pneumothorax. There is some air in the subcutaneous here that you can see, and also with pulmonary contusion. There's a little whiting of the lungs fields in that left chest that's associated with that flail chest. This is another picture of that pulmonary contusion, and you can see that there is some bruising of the left lung on this cut of the CT scan. Treatment of flail chest is supportive care, mainly pain control and varying degrees of pain control depending on how the patient is doing. There is some work out there talking about rib stabilization in terms of operative care, but there's nothing definitive out there to say that that's the main way to treat these patients just yet. We're going to go on to talk about massive hemothorax, which is defined as the presence of more than 1 liter of blood in the pleural space. The treatment of a massive hemothorax is placing a chest tube to allow re-expansion of the lung. There is some instances in which thoracotomy is going to be required to control bleeding, but this only occurs in less than 10% of cases. This is a picture of a patient who had a massive left hemothorax, and you can see that on the picture on the left, the entire left chest is filled with blood. The blood shows up white on the chest x-ray. The picture B is what happened after the chest tube was placed. There is still a little bit of residual blood, but you can see that most of the lung has re-expanded. The last thing we're going to talk about is cardiac tamponade, and this is something that's seen not that often, as a lot of patients who end up with tamponade don't make it to the hospital. There are some classic signs of tamponade that you may or may not see in the trauma bay depending on how noisy it is, but you can look for Beck's triad, which is distended neck veins, muffled heart sounds, and hypotension. And you should suspect this, especially in somebody who has penetrating injury within the box, and the box is defined as the nipples making the lateral borders, the costal margin is the inferior border, and the thoracic inlet is the superior border. So anything with that in that area can potentially be associated with cardiac tamponade, especially with penetrating trauma. So this is a picture of the box. You can see it's nipples bilaterally with the costa, with the inferior margin this way, and then the thoracic inlet up top. The reason why cardiac tamponade is dangerous is because it's a progression of the fluid in the pericardial space. You get blood in the pericardium, which then leads to decreased stroke volume, which then results in reduced cardiac output, which results in hypotension and eventually places the patient into shock. The treatment for this is decompression of the pericardial space, and this is just a picture, a 2D picture of what happens to the heart once there's fluid in the pericardium. You can see that there's very little room for the heart to expand once this area gets filled with fluid. So to treat this, like I said, it's a pericardial window. What you want to do is make a small incision in the subxiphoid area, and the incision is taken up into the pericardial space just right underneath the sternum, and you try to stay out of the peritoneal cavity. Once you find the pericardium, you take a little piece of it and open up the pericardial space and place a drain. And this, for the most part, should relieve the tamponade caused by the blood in the pericardium. Now, if you have somebody who has if you believe has a hole in the heart causing the pericardial tamponade, then you're going to talk about doing something other than a pericardial window. But this is going to be probably one of the easiest and fastest ways to initially drain out the blood if that's what you're trying to do. So that's the end of this talk. This is mainly just about blunt trauma to the chest and the 5 main things that you're going to find on your primary survey that could be potentially life-threatening. Thank you very much.